Welcome, good morning, good afternoon, and good evening. Thank you to everyone who's joining us today from across different time zones around the world. I'm Bryn Gay, and I will be chairing this INSU satellite session, Innovations in Hepatitis C Diagnostics, Real-World Implementation. I'm the Hepatitis C Virus Project Director at Treatment Action Group based in New York. And I focus on global advocacy related to hepatitis C, access to medicines, and harm reduction, particularly in the global South. I'm also a woman who uses drugs. Before we get started, I'd like to acknowledge the Lenape people as the traditional owners of the unceded land on which TAG's office is located, also known as Manhattan. You might see it in the background, and Indigenous elders past, present, and emerging. We'd also like to acknowledge the people who use and inject drugs and hepatitis C affect participating and providing their expertise today. Also, there are some changes in today's session. Jason Greebley of the Kirby Institute and Mauro Guarineri of the International Network of People Who Use Drugs cannot join us today due to other commitments related to the WHO Global HCV Guidelines development. And just wanted to note a couple of housekeeping details. If you have any tech support needs during the session, you can contact the team that's on standby. And there should be a live support button at the top of your screen. So meeting today is quite timely as we're updating the global guidelines on hepatitis C, which are expected in 2022. And also with the recent Lancet Commission on Diagnostics, it really highlights the access to diagnostics, the inequalities and inequities that exist around the world. We can all align our national policies and come up with really brilliant national testing strategies, but we need to find ways to overcome the implementation challenges. At last week's conference, it became even clearer that insufficient coverage of viral hepatitis testing services, even before COVID-19, is really a major barrier to increase access to care and eventually eliminate this disease. HCV testing services can be substantially improved using technologies and introducing new diagnostic tools. While good progress has been made in a number of studies and demonstration projects seeking to scale up and bring HCV testing and care services closer to communities, there have been challenges bringing these interventions to scale. And we need to really have a view towards bringing simpler, decentralized diagnostics to patients outside the lab. The objectives of today's session are to highlight key strategies to overcome real-world implementation challenges and to empower providers, community advocates, and peer action to scale up evidence-proven interventions to increase HCV diagnostics access in their practices, programs, and countries. By the end of the session, we hope that it generates awareness on real-world implementation challenges and that participants take away practical solutions that bring HCV testing closer to communities. I'd like to turn it over to our first speaker, and we're really delighted to have with us Dr. Tanya Applegate, who is a senior lecturer in the Surveillance and Evaluation Research Program at the Kirby Institute at the University of New South Wales in Sydney, Australia. Tanya has a strong interest in the development and implementation of molecular diagnostics on a range of infectious diseases, particularly among marginalized populations and those living in lower and middle income countries. To set the scene of our session, Tanya will present an overview of current and upcoming diagnostic innovations for hepatitis C with a view towards simpler near-to-patient technologies. So I'll turn it over to Tanya. Thank you.
Thank you so much, Bryn, and thanks to the organisers for the opportunity to take part in this very important conversation that needs to be had. As Bryn said, it's extremely timely at the moment. There's a renewed focus on diagnostics and access to diagnostics globally. So I'm really pleased to be here. So before I get started, I would also like to acknowledge the traditional owners of the land that I am speaking on here today, and that is of the Garigal people, and to pay my respects to elders past, present and emerging, and to all First Nations people everywhere. So as Bryn said, I'm going to give a very brief, high-level sort of overview of near-to-patient testings in HIV diagnostics. So as I just mentioned, and I'm sure you're all aware, but COVID-19 has affected us all in many ways. But one thing it has done is it's actually demonstrated what is possible, and that is, where there's a will, there can be a way. And what it also has done is sort of accelerated this concept of being able to deliver innovative testing and innovative implementation strategies nearer to the patient. So having a patient-centered approach and the realization of how important that is to successful implementation. So what I'm going to talk about now is what that means. Patient-centered approach or patient-centered care is really like, you stay right where you are, we'll come to you. You're already there, you're not hard to reach, we'll come to you. And the traditional ways of conducting it, over the last 20, 30, 40, 50 years, however long it's been, diagnostics have traditionally been centered in tertiary care settings where a sample needs to get collected from a patient and sent to a tertiary institution. But now patient-centered care is more about bringing the testing to where the patients are. So that might be in services such as community centres or shelters or mobile outreach services, needle and syringe programs, all the places that people are currently engaging or feel comfortable in coming forward. And so the idea here in the ideal world is that for someone already engaged in these services or able to reach these services, the patient would walk in, get a test and get the result, and ideally get treated. That's in the ideal world. And that's what we're referring to as like a single visit diagnosis. That is what you can refer to as the Holy Grail. But what we do need to understand also as part of that, with the diversity of everyone and everything, is that no community is the same. Every community has different needs. One size will never fit all. So there's not going to be one diagnostic solution for across the platform that will solve everyone's needs or meet everyone's needs. It's about finding the right mix of tests in the right tools. Remembering that no test is going to be perfect. So there are going to be some compromises depending on the mixture of tests or the single tests that you implement at your service. And ultimately, the ideal would be that you can limit the sample taken from the patient, but actually maximize what its uses can be in the number of tests that you can do from that one sample. So just going to very quickly talk about some innovations around near-to-patient diagnostic tests. So thanks to Sonjelle for this really beautiful snapshot. So when we think about innovations in diagnostic tests, we often think of new fancy tests that are coming through the pipeline. And this is very much the case and very much true, but it's not always the only angle we can think of. But as an example, I just wanted to raise the thought in your mind that there's always a pipeline of tests coming through, and it's actually quite a long process to get a test from its inception, its development, its validation, its approval, its funding pathway, all in place before it can hit the market and be available for people to use. And you'll be familiar, this is an example of the pipeline there's current for Hep C, thanks to Sonjelle and the FIND team. And you can see here that, for example, you have the Gene Expert that people are most familiar with and the Gene Drive that are available at the moment. And coming through already and coming through in 2021, you have another range of tests using perhaps slightly different sample types, different sample collection methods. But again, emerging new diagnostic tools that you can use at the point of care, such as AmorBio. And forward thinking into 22, 23, there are new tests coming along the pipeline, but it's not thick and fast. Along this pipeline, things drop off. But in referring back to the COVID world, what's happened is that it has received a flurry of new inventions, investment in transformational diagnostics for COVID. But hopefully along the way, they will all be able to pivot to Hep C as well, those platforms. So the hope is that we'll get more and more new diagnostic tools coming through. But we can also take a step back and think about, okay, we've got this pipeline of new tests, but how do we optimize the tools that we currently have? So as an example for NSP services, you can think about people that might be attending these services, potentially being younger, people who are currently injecting, so perhaps at higher risk of infection. In that setting, you're likely to have a higher prevalence of Hep C, lower level of liver disease in the group, and in this community, perhaps the time might be really important. So a reduced sense of time and urgency for needing that test quickly and the results quickly. So in this circumstance, an HCV RNA test and treatment model might really work, and then that could be followed up by coming back in later when you're visiting the service to confirm your cure, and again, monitoring your risk of reinfection along the way. So that's a test and treat model. In outreach services, you might be a different population where the HCV viremia might be lower. So there are alternatives that might be needed here. So where the cost of rapid, sorry, I'm using acronyms and I shouldn't have them up there, rapid diagnostic tests should be around a lower cost. The liver disease prevalence might be higher, but the time to wait and time to result might be a bit more flexible depending on the setting. So in these circumstances, it might be an oral rapid diagnostic test to screen for antibody might come first, and then followed by an RNA test, reflex it to an RNA test at the point of care. If they're positive for antibody, there might be an opportunity also or a need to stage in liver disease, and depending on the tools available at that service, how quickly that can occur, and then to treatment. So again, in these circumstances, we do have existing tools available for the first step in rapid antibody testing, and there are tests available also now for rapid RNA testing as well. But another model that we would need to think about in terms of implementation is, so point-of-care testing, while it would be brilliant to have, is not necessarily going to be available at all sites, and that is perhaps the rapid antibody tests might be more available, but RNA testing, there are things that we need to consider, and costs, etc. So in circumstances where rapid RNA testing might not be available, you can refer to hub and spoke models. So again, while we would like to be collecting very simple samples, and capillary blood is a perfect example of this in preference to phlebotomy, there are new ways to collect these samples, simple ways that you can transport them. So plasma separation cards exist, dry blood spot cards exist, and also microtubes exist where you can actually collect the finger stick and store it for a little while and send it off. So the caveats are that the cards, the dry blood spot cards, for example, they generally need to be processed in centralized laboratories with higher ability to turn over and more equipment available. But at the same time, there is research being conducted around how the other forms, so dry blood spots and the microtainer, for example, can be also then tested, referred to the DNA expert that's actually in the next suburb or in the next jurisdiction of the town. You can send them on motorbike. And one of the we're publishing a paper, or writing up a paper at the moment where we've been exploring the vacutamer, and it's performed very well in these circumstances. So just being able to reach people that aren't necessarily at the point of care right in their service at that time. So a hub and spoke model. But it's more than just about the test, which is really what this is all about. It's about implementation of point of care testing or testing as a whole. So we have the acceptance. You've got to take all these things into consideration, the acceptance to the clients, to the operators, to the providers, the linkage to care. How quickly can this happen? How important is it that it happens then and there? How available is treatment? Quality management systems overseeing all of this. What sort of systems are in place to ensure that point of care testing is performed correctly, interpreted correctly, etc. Education and training. This is all about not just conducting the test and being able to do it, but from the community's perspective, what the results mean, how can this be used? From the provider, how do you communicate these results? The funding of, obviously it's great having tests, but if there's no way to pay for it, then a sustainable pathway for funding will really block implementation of these tests. Policy in place about access and who should be receiving these tests. having in place the governance and a regulatory framework to make sure that all of these systems all fill in together and work beautifully, and also the reporting and connectivity. How important is it to be reporting these notifiable disease? How is it done? How is it communicated back to the patient? How is all of this data recorded accurately and communicated accurately? So just wanted to sort of think about, raise to your attention all of those things around. It's not just about the test. Implementation has a whole caveat of things. And the good news is, though, that there's a whole world of evidence being generated out there to inform all of this. So with that, I'd actually like to end and thank you all for the opportunity to take part again. So what I will do is now introducing, I think, to Sonjelle. Sonjelle will be speaking next. Thanks, everyone.
Great. Thank you so much, Tanya. Yeah, it's really interesting to see, you know, that you can have all of the latest, fanciest sort of diagnostics, but if you don't really address the sort of implementation barriers, if you don't think about, you know, the infrastructure that's needed, the community-led workforce, and, you know, just a lot of the, you know, training and task shifting that's going to be needed, you're not going to get anywhere in terms of getting back on track for, you know, scaling up diagnosis. So I want to dive into these issues later with our breakout groups. But first, we're going to introduce Sonjelle Shilton, who will be presenting a number of demonstration projects and real-world data to provide localized solutions to strengthen testing infrastructure. Sonjelle is joining us today as the hepatitis lead of the at the Foundation for Innovative New Diagnostics, based in Geneva. Sonjelle started her career in public health as Director of Operations of a community-based health outreach organization in rural Ghana, and she has over 15 years experience in leading programs in implementation science studies. So thank you so much, Sonjelle, for joining us. We'll turn it over to you.
Great, thank you. Thank you very much, Bryn, and thank you, Tanya, for that excellent talk. I think you've really helped to outline the key important things we need to be thinking about when we're thinking about diagnostics in this whole continuum of care. So we know that we have a lot of people with hepatitis C, and what do we need to do to find them and get them linked to care and get them cured? Well, what we need to do is decentralized targeted screening at places where people already go for care, with reflex testing for RNA and liver staging, and decentralized treatment. So this one-stop shop. When we talk about one-stop shop, I feel like this word is coming up, or this phrase is coming up more and more. What do we mean when we're talking about that in terms of the diagnostic portion? Well, one thing that is important to bring up is that one-stop shop can use existing infrastructure. I think Tanya highlighted it really well. You know, the point of care machines are excellent, but they're only as good in the system that they're placed in. And there are a lot of other ways where we can bring care to the patient, right? It doesn't have to always be the point of care molecular testing platform that does it. You can leverage on the existing systems to reach people where they are. And as already highlighted, I think really wonderfully, it's about thinking about the patient journey. The most important aspect is to make it easy for the recipient of care. If you move them, you lose them. I mean, we've seen this in a lot of other health conditions, and it holds true with hepatitis C. And there's lots of evidence that the one-stop shop works. So there's a recent systematic review, over 142 studies, and it showed higher rates of linkage to care and treatment uptake with the fully decentralized one-stop shop model compared to all the other models that are out there. So when we think about diagnostics, one-stop shop, real-world implementation that has an idea to scale up, okay, how do all these pieces fit together? So I'd like to discuss two examples of a implementation pilot that has been scaled up nationally, and that has two different approaches to using diagnostics to facilitate this one-stop shop. So the first example is what we call Head Start Georgia. So something that FIND has done in cooperation with the National Centers for Disease Control in Georgia, Georgia Harm Reduction Network, Health Research Union, all of the harm reduction sites. And this is, I think, the first common theme throughout it, the effective pilots that have been scaled up and have been able to sustain involve a lot of people, and it involves bringing together a lot of the important stakeholders from the whole cycle of care. Now, in Georgia, so the country of Georgia has a very advanced hepatitis elimination program, and they were trying to understand how they could improve their cascade of care among people who inject drugs who attend harm reduction sites. Because what they were seeing is they were offering the hepatitis C antibody rapid diagnostic test at the harm reduction site, and then the patient had to go to another site for further viremia testing and then to be linked to care. And they were seeing that up to 60% of clients who were testing rapid diagnostic test positive at the harm reduction site were not getting to that second step. So they wanted to know, okay, how can we fix this? So what we thought to do was put 4 gene experts, so that's the near point of care molecular technology, at 4 different harm reduction sites. And 2 other harm reduction sites, what we did was we implemented what's called reflex blood draw. So after the rapid diagnostic test is positive, then the participant immediately gets a venous blood draw, and that's sent to the centralized confirmation. So kind of like the hub and spoke model that Tanya was talking about. And then in 2 other sites, we just had it business as usual. So the client gets the rapid diagnostic test at the harm reduction site and then has to physically go to another site. So as a result of the study, and I'll show the care cascade in the next slide, but what happened was the participants, both that got the molecular point of care and the reflex testing, had really excellent rates of viremia testing. So because of this, the government has decided to scale up the reflex blood draw throughout all the other harm reduction sites in the country. They don't have enough money to put a $17,000 machine in all these other harm reduction sites, but they certainly do have the ability to leverage the existing infrastructure, the existing sample transport networks, and et cetera, to bring the sample reflex to those harm reduction sites. And additionally, the study helped with the efforts of many other people to get the treatment decentralized to some of the harm reduction sites during the course of the study. So at the very end, about 60 people of the 1,600 in the study were able to get the one-stop shop model. And we look at this cascade here, and what we see is the expert arm and the reflex sample arm, 100% and 99.8% of those participants who are RDT positive got that viremia test. So that's excellent. But what's important to note is if you look over at the treatment bit, there's not very much different. And that's because the majority of participants still had to go to that second place to get all the other workup and everything done before they could initiate treatment. So it just goes to highlight that you can have really great the diagnostic part in the first part, but as Tanya was highlighting, if you don't have that whole holistic system, you're still not going to get to where you want to go. Another way of looking at leveraging existing infrastructure to scale up a decentralized testing model is the Malaysia Head Start. So now in Malaysia, the government has fairly recently embarked on like a solid program to try and tackle hepatitis C. And what we did is we worked with the Ministry of Health Malaysia and DNDi, and we integrated hepatitis C rapid diagnostic test into 25 primary healthcare clinics. Now, the model is a little bit complicated, honestly, because participants would have to come to the primary healthcare clinics, get the rapid diagnostic test. If positive, they had to physically go to the district hospital to get their blood drawn. And then if they were viremic, they could either get treated at the primary healthcare or the district hospital. So it was like not that great of a, I mean, it wasn't as strong of a care cascade as we would have liked to see. Because we were working so closely with the government, and the government was their primary investigator on this, they saw the data as it was coming in, and they were like, we've got to be able to be more impactful. So what can we do? All right, let's decentralize treatment to primary health care, and let's make it a one-stop shop with the best of our abilities. So now when a participant comes to a primary healthcare clinic, they get the rapid diagnostic test, and then they get reflex blood draw, which is sent to the district hospital or another centralized lab. And then they're able to start treatment in most cases at the primary healthcare center. So the sample moves around a whole bunch, but the patient can stay at one place. And so this model has been scaled up from the 25 healthcare clinics that we piloted at to over 200 clinics today. So then with Malaysia, like what's next? Well, one thing that they could do is expand treatment to community-based organizations. They had some of that, and it was kind of like on a as funding basis. But then with COVID and funding, challenges, they weren't able to continue the community-based testing. Particularly, the COVID lockdowns in Malaysia have been pretty intense. And so one of the things, I'm just going to skip through this slide right now. One of the things that they are wanting to do is hepatitis C self-testing. So FIND, in cooperation with Malaysia AIDS Council and the Ministry of Health, we have recently started the first ever real-world hepatitis C self-testing impact study. We started enrolling participants in September. We're using both the blood-based and oral fluid hepatitis self-test. And now we've only enrolled about 170 participants so far. But of those, what we see is participants in the self-testing group compared to the control group, which is just being referred to a primary healthcare for screening. The ones in the self-testing group report 60% higher uptake of hepatitis C testing than those who are in the control. So it's super early data. We'll see how it plays out, but it's just it's an exciting step to the next step of bringing testing closer to the patient. So just in conclusion, I'd like to say that I think the primary thing, the most important thing, and the thing that may have made our work the most successful was bringing together those people, making sure that we worked not only with government, but that we tried to help facilitate connections with civil society, connections with patient groups, connections with people with lived experience. And through that kind of gathering a holistic approach, we were able to move forward. So thank you very much.
Thank you so much, Sonjelle. That's really, really amazing. And I'm just really impressed with the care cascade in Georgia. I don't think I've seen anything like that. So well done to just providing additional evidence. I think all of this is really informative for the global guidance and also to other countries to how we would potentially adapt that into our own national guidelines. And I just think that some of these lessons are, just awe and inspiring. So congratulations to all that hard work. So I just wanted to mention that there is a live chat or a live Q&A if anyone has any questions. So like for Sonjelle or Tanya, and we will be transitioning into a couple of breakout groups. But before we do that, I just wanted to introduce a topic, and stepping out of my role as chair, I'm covering a topic that was going to be covered by another speaker. But really, I just wanted to introduce that there are a couple of other implementation challenges that that we're starting to see related to licensing, pricing, and access. And I think that this was just to highlight some of the community advocacy efforts that have been taking place. For instance, we know that a number of these diagnostic platforms, which are funded by the Global Fund programs, they may be licensed only for one disease. So there have been efforts to try to advocate to run hepatitis B or hepatitis C tests on those platforms when they're not being used for those other diseases. But this has been fairly challenging. And I think another sort of advocacy area has been around how to negotiate prices and how to bundle your tests so that you get maybe a better deal when you're negotiating. And there's also been some community advocacy related to the public funding that has gone into the development of diagnostics. And some of the advocacy includes unlinking the cost of production from the list price to inform negotiations during procurement. So I just wanted to highlight a couple of those advocacy efforts and campaigns, such as the Time for 5 campaign, because one of the breakout groups will be discussing, pricing, licensing, and access issues. So I'm just going to quickly look to see if there's any questions in the Q&A. Sure. I don't see any questions at the moment, but we might dive into these issues in detail. So I think we have a bit of a change as well. We have a very intimate group. So I wanted to invite our facilitators and discussants that will be joining the different breakout groups. I think we're going to be dividing them into two different breakout groups. So people have a choice to join group 1, which would cover the topics of bringing testing closer to community, which we have a discussant, Rajkumar Nalinikanta from the Community Network for Empowerment in Manipur, India. And we also have the group 1 will also cover the topic of guidelines changes for task shifting. And our discussant is Olga Denisiuk of the Alliance for Public Health in Ukraine. And this topic, the focus of group 1 will also cover policy and regulatory changes. So we have a range of issues that we'd like to discuss in terms of what are the implementation challenges and related to bringing testing closer to community, guidelines changes for task shifting, and policy and regulatory changes to finance and accelerate diagnostics approval. So that'll be group 1. And then group 2 will be focused on community mobilization to bring hepatitis C testing in Indonesian prisons, as well as pricing, licensing, and access advocacy. So we have presenters Carolyn Thomas of Peduli Hati Bangsa in Indonesia, as well as Francisco Viegas from the Drugs for Neglected Diseases Initiative in Latin America, who will be joining group 2. So you should see on the right side a panel where you can join breakout groups, and we'll be able to talk amongst ourselves and dive into these issues. The focus will be really to come up with what are the key issues and challenges that you identify according to these topics, and then we'll report back to the main floor at the end of about 45 minutes. So we'll see you in about 45 minutes, and thank you. Thanks for joining the first part of this session. Welcome back. I think we were all caught in some very interesting and we were just caught in these amazing conversations. So I think it would be really interesting to hear across the different breakout groups based on what we've heard. You know, we had a lot of, at least in group 1, we had a lot of community-based initiatives. And I think this is really where we can exchange some of the lessons and hopefully maybe adapt or integrate those into our own programs and advocacy. So I would like to ask, other participants in group 1 to maybe report on some of the takeaways. So maybe I could ask Margaret Hellard and Lizzie Levenger to share some of the takeaways related to community-based initiatives, bring testing closer to the community, some of the takeaways related to how do we finance hepatitis C funding, hepatitis C programs, and also some of the ways that advocacy has led to shifting tasks in national programs. So I'll invite facilitators from group 1.
Thanks, Bryn. And thank you, everybody. And thanks for a really interesting discussion. It was a little weird. We came flying back. I wasn't quite expecting it. I think from group 1, what really came across super clearly was the importance of the central role of community and community-based organisation in extending opportunities for care, for bouncing from COVID into care around hepatitis C and also the other bloodborne viruses as well, because as we know, often with the key populations being impacted, it's not just Hep C, it's either Hep C and HIV or other things. So to me, the first thing I think was that the centrality of community and the capacity of community to provide the care that's actually required. And I think this is something that we constantly, in my view, underestimate, and that we need to continue to build on. And part of the reason I think we underestimated it has been really hard. I know even in Australia, when I do work in this area, hard to provide a clear, what I'll call evidence base that can go into guidelines about the role of community and peers. And it is a really hard thing to measure that impact. I often try to work out how to measure things for guidelines that I sometimes think are obvious. I say that I'm often doing research to prove the bleedingly obvious, but some things are really hard to actually measure in a way that then guidelines will say this is a high quality evidence and those kind of things. But I think the speakers, all of them talked about that. Some really, one of the questions that really interested me as well is then how do you, if you're doing testing or work in community, then link to a health system or service? And I think this always remains a challenge. But again, there were some really interesting sort of discussion on the solutions for that, and some, you know, sort of tracking, and whether or not and how you're providing that information to government, that linkage. So I think that was sort of a critically important issue that was raised. And then our final person was, I'm just having a mental block, and then was just speaking about treatments and funding for treatment and opportunities, and how we should be really, again, continuing to think about exploitation of global fund, and sort of Emi was discussing the use of in community-based work or whatever it might be, that leftover global funds, and making sure that you exploit them to work with key populations. So to me, again, as I said, my sort of takeaway message was centrality of community, get testing out where people are, and then sort of find innovative ways to sort of link it back to the central system, but don't expect the central system is sort of the end part, not the beginning part. Thanks.
Yeah, I absolutely agree with all of Margaret's conclusions. And I think sort of building on the point about the centrality of community, what I really took away from our breakout group was the sheer creativity that has come out of community in addressing you know, where sort of policymakers have fallen short, and how to better link folks to the diagnostics and the treatment that they need. And so I think that was particularly striking. I also think one of the notes that was really interesting, just to sort of think about going forward, was how to build upon where other parts of public health financing might be sort of ripe for hepatitis investments, and might not yet be there, but have the potential to. And really curious about how, in the context of COVID-19 and how that has shifted around public health investments, what that has meant. And also how that has impacted the ways that community has sort of come in to fill some of these gaps. But yeah.
So I really appreciate the insights on the need to support communities in all these efforts. And you know, I'm also curious to hear what you know, others have found in the second breakout group. I think that you focused on the role of community in providing test and treatment initiatives in prisons, as well as the role of communities and just advocacy related to the overcoming other access barriers, including pricing and out-of-pocket costs. So could Tanya and then Sara share some of your takeaways and insights from your breakout group, please?
Yes, thank you. It was, again, we're extracted from this conversation. We're deep involved, some really juicy conversations that we would love to unpack more. But from the conversations that we did have with relation to the top level messages and the role of community, perhaps there was, from a very practical perspective, we were talking about how important it was from a country perspective. The prisons do offer a place for targeting a high prevalence population where the need is very, very strong and clear. But the efforts around the practical aspects were making sure that were able to use existing workforce as best you could to enable a sense of sustainability going forward. There's no point putting all these people in action and then withdrawing them from that. So it was about increasing the capacity of the existing workforce to take those roles on board and to facilitate that. And the importance of simplifying those procedures, so that, for example, at the moment in the prison setting, in the Indonesian example that were given, and some others that Sonjelle was expressing through other countries, the actual physical process of the collecting the blood and many steps involved in that just for the first stage of antibody testing was quite restrictive and limiting factor. So anything in terms of whole blood processing rather than requiring plasma from a practical perspective would improve that. Also, simplification of data entry management or the paperwork that's required. Anything that can facilitate the existing workforce to do these roles as simply as possible in their day-to-day life was something from a practical perspective. The next point I think that was brought up was around the importance of the community in terms of advocating for pressure. So there are certain points where stockouts just completely blocked the program for long periods of time, and it was advocacy, getting online petitions, making sure that the government were responsible for doing something about it, because it's very hard from the community perspective to change that when it's in place. So that role of community advocacy and pressure for stockouts was also then raised with regards to the competition as well. So for example, there was one drug available at the time, price was very high, bringing the others in and then advocating for those prices came down, but it did take 3 years to something that was affordable simply because there was competition on the market. So that then applies to the diagnostics as well, and that concept of competition and monopoly were held very strongly through the discussion. And so I think there was one concept that was brought forward by Francisco in particular around we need to take we're focusing on these smaller one-by-one infections and platforms, but we actually need, there are examples in the treatment world with regards to increasing access for licensing and the IP and that allows greater access to these technologies at an affordable price on a whole ecosystem level. So I'm probably not the right person to perhaps, Sarah, you might like to speak to that more, but it's really a holistic ecosystem approach that we need to take to diagnostics, not necessarily Hep C in presence and that particular test at mind, because otherwise we're going to be constantly stuck in these small battles, these small conversations. We need to sort of elevate it to a broader access. And I think TAG, for example, it's Time for 5 is absolutely an initiative that provides an example of where we need to apply that pressure for the rethinking at a global level. So I think apart from that, we also touched on interestingly different concepts around very localized perceptions of what the priorities are, as you would imagine within prisons, but also among prisons. So I think it would be good to go from the very practical, specific action items that we have in place, but then taking the step back to a global approach to how can we completely shift this thinking in access to diagnostics. So Sarah, would you like to add to that? I'm not sure that I've touched on everything or very well, so please add.
You did a great job. I just wanted to raise also a point that Francisco spoke about, that a lot of these technologies, both with the treatments but also with the diagnostics, are developed with public funding and by public institutions. So they when they reach the market, they are out of reach of a lot of for a lot of people, even though they were funded by public money. So that's something to keep in mind. I think that's a discourse that we hear a lot on the treatment side, but on the diagnostics is also true, and that's also a pressure point to bring up. And what you said about the competition too, I think Sonjelle also touched on that there's a reliance on a very small group, or sometimes just one platform, just one provider for diagnostics, and that allows that allows a virtual monopoly on the price, and that's something that starts on the development of the technology, how it's licensed, and how it goes through all the steps and path to reach point of care. So that, I think that connects with what Tanya talked about, the localized and what we see in the point of care, what people are needing now, but how that connects to this whole tangled web of how technologies are produced and licensed and purchased. So that's a lot of food for thought. I think we were very deep in the discussion. I think we could, like Tanya said in the group, we could stay here for 6 months and still have a lot to talk about. But I think that those were the points that stick out for me the most. And I think also, we touched briefly on this about the stigmatization of populations and how hard it is to move the governments to prioritize the populations depending on how stigmatized they are. I'll stop here because I think we have 1 minute and Bryn needs to say goodbye to everyone.
Right, and I'm sorry to jump in and that we are running out of time. This really takes a multi-pronged approach, and as Tanya and others have said throughout the session, that there isn't one size fits all for addressing the diagnostics gap. I wanted to just wrap up the session and really thank all of the presenters, the facilitators, the discussants, and note takers who've been dialing in from various time zones and meeting very late and very early. So really much appreciation to everyone who's been able to join us today. And also thank you to the INSU team, ASHM team as well. This has been a really excellent session. So I'll wrap up there, and hopefully we'll see each other next year in person. So thanks again for all of your contributions.
Thank you. Thanks, everyone.